But thank you everybody for being with us today. We're very excited to hear all the things that Dr. Spiritus has to say. I do want to remind everybody that this is being recorded. So if you could just do your best to keep your mics off, just so we don't interrupt each other. But if you have any questions, you can feel free to put them in the chat. I will monitor that, and we can do a little bit of a Q&A after he's done chatting with us. So if you want to get started, introduce yourself, and we can go from there.
Hey everybody, I'm Zach Spiritos. I am a gastroenterologist. I do a lot of neurogastroenterology. So I think like broad strokes, see a lot of people who have a lot of symptoms, but all of their diagnostic testing ends up being equivocal or negative. But I also do with I see a lot of motility issues as well. That definitely includes gastroparesis. Kind of altered small bowel motility, colon dysmotility as well, of all shapes and sizes. Yeah, and that's what I do. I see a lot of people like dysautonomia as well. So we treat POTS. I see a lot of like comorbid mast cell activation as well. I see a lot of people with hypermobility too. And that's generally the world that I live in, the folks that I see in clinic a lot.
Thank you for sharing all of that with us. I know most of us probably have found you via social media because that's where we live live these days. And you do share a lot of information about gastroparesis and all these other conditions. And I think what brings a lot of us in here is either gastroparesis being our primary condition or maybe secondary to POTS and EDS. And a lot of the struggle that we tend to see in the groups and for a lot of the people here is, what do you do when everything is flaring at once? How do you make the decision of maybe what to treat first or what is triggering something else? And, what would you suggest if someone's coming with you with all these complex conditions? I know it's very generalized and we can't get down to the nitty gritty because everybody is different, but maybe, where would you start in treating something like that, especially when it's such a delicate balance to keep everybody as healthy as possible?
Yeah, I mean, I think it all depends on like what's causing the flare. And so, say for example, someone with gastroparesis and they don't have like mast cell activation syndrome, they don't have POTS, and we're talking about like a gastroparetic flare. And oftentimes that can be just like horrendous nausea, nonstop vomiting. We first want to identify like why it was there to begin with. And that could be, I mean, most commonly a dietary trigger, whether that's eating too big of a meal, eating too fatty of a meal, eating really fibrous meal, but also could be like stress too. It could be getting too little sleep the night beforehand. It could be an argument with somebody. It could be a bad breakup because that has a tremendous impact on how we feel our GI tract. And kind of in line with that, one of the therapies for gastroparesis is this gastric emptying, this gastric stimulant, which we hear all about. And it does nothing to actually affect the way that your stomach empties. It's all about sensitivity, right? And so when people get nauseous with gastroparesis after eating, that is not necessarily a reflection on how the stomach is not moving or accommodating, but it's a abnormal sensory issue. So when people get kind of gastric stimulators, it doesn't help the stomach empty any faster. It really just helps with the perception of what's happening in your stomach and the signals from that stomach via the nerves to the brain. And so in that same vein, getting poor sleep, a lot of really having a tough time at work, can all affect the way that we perceive our GI tract and kind of throw us through a loop as well. So I always start there with like what really caused this. And if it's stress, stress management is like the silliest term out there, right? Like it doesn't, how can we avoid stress? But it's finding kind of maybe compensatory mechanisms. Like if it's, we know that getting a poor night's sleep really affects the next day GI symptoms and how we perceive our GI tract. So if it's like, okay, well, you're getting bad sleep and your job has been really, really tough or exams are coming up, like let's work on the sleep piece of things, which that's kind of a different dialogue. If kind of your thoughts are what kind of throws you through a loop, like, oh, I got this call coming up and your thoughts start going like, now I'm really worried about what's going to happen during that call. And that's what throws you through a flare. Then we talk about like cognitive behavioral therapy or hypnosis or things like that. Sometimes people benefit from pharmacotherapy as well, like SSRIs, SNRIs, things like that. If they find that that's causing their symptoms. So that's kind of where I start, is what's triggering this. And if we're talking about gastroparesis specifically, and say, for example, nausea is really, really bothering you, then we've got to find a way to abort the nausea when it happens. So we kind of have this break glass in case of emergency pack of like therapies to use in a pinch. That could be Zofran, it could be Phenergan, it could be Ativan, like a benzodiazepine. Um, and Reglan also for those people that if Reglan works for you. And then you can kind of go up and there's, amend and things like that that are a little more challenging to get, but definitely pack a punch. So that's kind of how I think about flares. Mast cell flares are completely different, right? Like what triggered that and therapies we use. So I think it all depends on um, what is flaring. Is it POTS? Is it mast cell? Is it gastroparesis? Um, what's driving it, and then identifying kind of a party pack of medications to kind of get you out of a pinch or get you out of a jam when you're overwhelmingly symptomatic.
Now, I know you kind of touched on this a little bit, but when we have like one condition that flares and, it really does set that snowball effect of everything else starts flaring and you just keep going down the line. I know you said you want to identify what really starts that, especially if it's gastroparesis and trying to get the nausea under control, like what's your biggest symptom that's causing that flare. But really, why does it seem that everything kind of happens at once? Do you think it really does all come down to the stress, whether that's mental, physical, or combining of the two, of the body just gets in that fight or flight mode and you really just you don't know if I think we've said it, we see it in memes all the time where like you don't know if you're answering an email or if a bear is chasing you. Your body really can't tell the difference. And that can really set everything off. Would you agree with that in talking about stress management and really trying to say, is this going to set everything off? And this is really one of the main causes why everything just kind of combusts all at once.
Yeah, I mean, living in fight or flight or kind of sympathetic overdrive is a tough place to be. Everything gets magnified, right? If I get an IV placed in my arm after a night of good night's rest and I get breakfast in my system, I can tolerate that IV pretty well. But if you try to put an IV in my arm after I've been sleeping for 3 hours and drinking coffee all morning, like that's going to hurt a lot more. Our kind of the level of stress, so to speak, or anxiety, what have you, directly affects the way that we feel everything in our body, right? Everything um, is augmented. So there's something called the gate control theory that our brain is a really good way of kind of calming down peripheral sensations. Like your brain needs to know if you're getting chased by a dinosaur. Your brain needs to know if you step in a bear trap. It doesn't need to know how your stomach and intestines are moving. It doesn't need that information. It is so overwhelmed by like having to see like you have to do your work, you have to take care of your kids, you have to drive. Like your brain has a lot on its plate. But in someone who has a lot of kind of stress or anxiety, the brain has a really difficult time tuning out those signals. And so everything is felt a lot more. And that's called central sensitization, where everything just the pain, the in you're just that the volume is just turned up. And that's why people use medications like amitriptyline and Cymbalta for chronic pain because it works on that central processing of pain. Um, and it doesn't work for everybody, and it's an antidepressant. So people are, there's a lot of dialogue about like, why are you putting me on an antidepressant? But it's like that's how it works. It works in the central pain processing systems. I will say that like in someone who has like chronic illness, mast cell activation syndrome, gastroparesis, dysmotility, and things are really challenging on a day-to-day basis. Symptoms are challenging. You don't know what's going to make you feel. There's so, unpredictability with your symptoms. It can keep you out of work. There's going to be inherent stress and anxiety with that, right? And so just to say manage your stress is kind of ridiculous because it's impossible to do when the pathophysiology is running out of control. So I will honestly, in my practice, and I think everybody's different, is that I will try to alleviate symptoms. Well, talk to people about what their diagnosis is and try and educate as best I can about like why things flare, how things flare, what's happening in a flare. So you can understand. Cause I feel like when people understand what's going on in their body at that moment, you kind of become you're in the driver's seat a little bit more as opposed to being completely at the will of what's going on. And then I will honestly control the condition itself, or I try to with medications. Because I feel like if you're so focused on like, I just need to control my anxiety and my stress, like it's just, that's an end to actually treating the condition. So can stress and anxieties trigger symptoms? Sure, absolutely. Is that the only cause? Absolutely not. There's real inflammation or real dysmotility going on. I think it's tough to have a conversation about addressing the stress and anxiety that could in turn be causing a lot of symptoms without addressing the condition itself. So, for example, stress and anxiety can make mast cell really, really, really tough, and people flare all the time. It can make gastroparesis a lot worse. But man, if I just say, hey, we're going to institute some breathing therapies and diaphragmatic breathing, hypnosis, cognitive behavioral therapy without actually addressing the underlying inflammation, dysmotility, autoimmunity, it's going to be really tough to do. So I think both coexist.
I like that you focused on that too, because I think just from my personal experience, and I know from hearing from a lot of different patients and their different experiences, that when you focus on one or the other, you really don't ever get that far. You only get to a certain point and you've maybe exhausted everything that you can exhaust because you didn't combine both of those treatments together. And as someone who thought diaphragmatic breathing was silly for a very long time and then actually started implementing it, I realized what a difference it made in addition to all of the other treatments and all the other pieces that really affect the gastroparesis and my motility issues. But um, one of the things that I wanted to ask about was the typical gastroparesis diet. Now, we all know that at some point or another, we all were just told to stay away from just food, right? They're really that typical like low fat, low fiber, no tough meats, no skins on vegetables, cook everything down, soft foods, which can be very beneficial for a lot of people. But when you have these other conditions, something like POTS, where you have to hydrate a certain way, you have to have certain levels of sodium in the body to really help keep those symptoms at bay. So, how do you suggest starting with sticking to the gastroparesis diet, whatever that means to you, while also supporting these other health needs as well? Because that can get a little bit difficult to do. And I think we all have to go through that trial and error, but it's kind of hard to know where to start when the typical have this or don't have this sometimes go against each other when you have both diseases. Which do you choose first?
Yeah. Man, that's a good question. So
Sorry.
Sure. No, it's a great question. I think it's tough to give a generalized statement because it is so personalized. So I guess if I'm talking to someone with gastroparesis, and let's just take down the diet first. So everybody knows the diet. In fact, I find that if people with gastroparesis, when I start telling them the diet, like they already know the diet. Their body is telling them they don't like roughage. Like salad's not anybody's friend with gastroparesis. That eating a cheeseburger is not a good idea. Like they know this. They have insight into what is going on. So I just kind of try to explain like why, if they haven't already done a deep dive and got an understanding for the diet itself. And then we kind of talk through, and I by no means am a dietitian, but I kind of lay the groundwork here. That we kind of I talk about how the stomach is a blender, and in gastroparesis the blade is a little bit dull, and so you want to give things that are pre-blenderized to the best of your abilities. And obviously being on a liquid diet is extreme. Sometimes it's necessary, but it's extreme. And we talk through like, the more blenderized the food is, the softer food is, the easier it is for your stomach. And that's kind of, we need to identify safe foods. Um, but unfortunately, a lot of safe foods are brown, right? It's the mashed potatoes, it's the rice, it's the pastas, because they're carbs. Carbs are really easy to digest. What's hard to digest is fiber and fats. And that's what makes gastroparesis kind of go nuts. So we try to think of creative ways to get fiber and fats in your diet. So I prioritize fiber. Um, and we talk about, instead of a carrot, like cook and blenderize the carrot. Broccoli is kind of a tough one. Same thing with potatoes, kind of cook it down, blenderize it. Like everything should be kind of a puree, but it's because it's important to get fiber as well. Then I usually recommend like a general multivitamin for people as well, because it is tough to do everything. And then based on kind of how they're feeling in terms of their satiety and being able to eat, well, one quick thing. I want to make sure that their symptoms are actually due to gastroparesis as opposed to mast cell activation syndrome, because there's huge overlap. And there's also something called MALS, which is median arcuate ligament syndrome, which is different. And the reason I say this is because there's a lot of people with abnormal gastric emptying studies, but their symptoms are not necessarily due to gastroparesis. And I'll explain that in a little bit. Or explain it right now. So in gastroparesis, right, the stomach doesn't empty very well. And so the way that I tease out whether your gastric emptying study, if it is truly delayed, is reflective of your current symptoms as discussing what makes your symptoms worse and what your symptoms are. So generally speaking, gastroparesis shouldn't hurt a lot. It just shouldn't. Sometimes it can hurt a little bit, but not a lot to where it's becoming a barrier to eating. Um, it is more of this kind of like, like get full early, nausea, and then you can vomit afterwards. Big meals, solid foods, roughage, fatty meals, those things tend to reliably make mast cell worse. And when you kind of downgrade to a liquid diet or a soft diet, things generally seem to get better. Um, Mast cell can have very, very similar symptoms where people get full early, but it's different. The foods that affect people aren't necessarily due to their consistency or fat content. It's kind of random. It's like avocados and alcohol and tomatoes and fish and leftovers, right? It's not like it doesn't fit into like the gastroparesis, like it's, bigger meals, kind of more solid foods. There's a lot more idiosyncrasy and randomness to the mast cell. And there's methods of the madness in the sense that a lot of these foods are like higher in histamine. It can cause a lot of issues there. Um, and there's something called malls, which is kind of in this world of kind of postprandial symptoms, but that's a lot of pain where everything hurts. Water, solids, doesn't matter how much, doesn't matter how little. It could be a smoothie, it could be a Whopper from Burger King. It all hurts the same. So I think I bring that up because there's a lot of people that come to me and say, my gastroparesis is ridiculous. I had a patient today who says, my gastroparesis is out of control. I just lost like 40 pounds in 3 months. They can't eat anything, even water hurts. That is not gastroparesis. That is something different. Gastroparesis shouldn't hurt that much. So that's what I try to identify first is like, okay, are your symptoms actually due to gastroparesis or not? And if it is, and we need to manage, water intake, sodium intake as well, we talk about the diet and what are the limitations there. And then, if we need medications, we need medications. I am not afraid of Reglan. It gets a bad rap for a lot of reasons. Reglan, there's not a lot of data to support it. It also doesn't work incredibly well. It works much better if used in conjunction with diet. And Reglan, albeit has a lot of potential issues with it, especially neurologic issues, which are always really, really scary. But it can be an adjunct therapy here. And then obviously if people progress beyond that, then we say like, okay, or I think we talked before, Samantha, about pyloric directed therapies like poems and so it all depends on what it is. So what's going on? So gastroparesis is a heterogeneous group of it's not one thing, right? It's a lot of it's based on how you got there. Diabetic gastroparesis is categorically different than post-surgical, which is different than dysautonomia and POTS. So in people with POTS, typically, well, let me start with gastroparesis due to diabetes, which is easier. Usually that's just the stomach, usually. And so if you're still struggling with diet, Reglan, other neuromodulators like nortriptyline and things like that, then you can talk about pyloric-directed therapies for the right person. That's kind of a bigger dialogue. Pyloric-directed therapies involve either putting Botox into the sphincter or cutting it with something called a poem. You have to kind of find the right candidate for it. Not everybody's the right candidate, so to speak. And we know that people with like autoimmune gastroparesis and diabetic gastroparesis tend to respond the best. And it works best for symptoms primarily like getting full early and nausea. It does not work for pain. And people are very selective about who they bring for poems and pyloric Botox because we're not quite sure who it works for, and it doesn't come necessarily without side effects. So it's an important conversation to have. I bring this up because I've had folks with POTS and dysautonomia who were referred for pyloric Botox. But I will say, if you have dysautonomia, that same as in contrast to diabetic gastroparesis, where it's usually just the stomach, in dysautonomia, it usually affects the entire bowel, the stomach, the small bowel, and the colon. So if you do a pyloric directed therapy like Botox, guess what? Your small bowel is not moving very well either. So it kind of defeats the purpose. So in that situation, you want to look towards, I often find that people with dysautonomia can have really, really, really bad gastroparesis and small bowel emptying. And that's when you talk about immunotherapies. And that's usually a conversation for a neurogastroenterologist or a neurologist to talk to you about to identify if you're a candidate for IVIG and things like that to help move things along. So I guess this is a long way of saying that it's very, very personalized. And our goal is to get things moving as best we can. There's a lot of ways to do that, not only with diet, medications, and potentially surgical interventions, but also immunotherapy as well for the right person.
That was a very, very thank you. That was very, full of information. So, it is hard asking these questions, especially because they are so individualized and there's so many different pieces, like you mentioned, with diabetic gastroparesis versus autoimmune gastroparesis, post-viral. There's all these different things that can really change what that treatment is. I We did get a question on our Facebook page about chronic migraines in conjunction with gastroparesis, and I'm not sure if the person that asked the question is here now, but I know that they were saying that there was a lot of or not a lot of information on people who've been diagnosed with chronic migraines and how that can flare up gastroparesis symptoms. Do you see a lot of people in clinic, or do you have any information that maybe you could share about why sometimes those symptoms can go together beyond just the sometimes migraines can cause nausea and that can maybe kick off some gastroparesis symptoms, maybe beyond something that seems so obvious?
Yeah, every patient that I have in clinic has migraines, every single one. Um, and it's not by any coincidence. And so I think it's a complex conversation to have because also migraines, migraines kind of get lumped together with headaches. Okay. And so in people with hypermobility, mast cell activation syndrome, postural orthostatic tachycardia syndrome, the prevalence of migraines is almost 100%. And it's a really, I think it's a tough conversation as to why it happens, but it's multifactorial. And when I talk to people or try to ameliorate these migraines, I put people in migraine therapy all the time because migraines are debilitating and they suck. But I will also treat their POTS, with the variety of techniques we have to treat POTS, and I will treat their mast cell activation syndrome because mast cells are also not only located on environmental surfaces like our skin and our GI tract, but they're also in our dura and our meninges as well. And centrally, kind of acting up mast cells can cause a lot of migraine headaches. But you also talk about in people with hypermobility, they have, craniocervical instability and a lot of like super tight kind of upper cervical muscle tenderness that can lead to kind of these kind of cervicogenic migraines. So I will say that migraines are almost I'd say everybody has some flavor of migraines in clinic. So the question is gastroparesis and migraines, are they linked necessarily? I wouldn't say so in the sense that I don't think one causes the other, but do they both occur in similar patient populations? Yeah, they do.
I can concur as one of those patients. Um, so we did get some questions.
Ask your doctor for CGRP medications. I'm dead serious. Like they are like I've spun my wheels in the past with triptans and amitriptyline, and I'm kind of done with these now. I just go right to the CGRPs. Insurance may push back a little bit, but they work so well and they're just really, really safe. And it's one of those therapies that, they're new, they're expensive. So sometimes you're like, oh, you got to fail this, you got to do this, or like maybe let's put it off. But quite frankly, I find them to be better tolerated than most other medications, and their safety profile is great, and they work so incredibly well.
Oh, that's good. Thank you for sharing that. I know, like I said, as a migraine patient myself who's been fighting one for a few days, and it does tend to pick up other symptoms too. But that's with anything, right? And kind of the generalized consensus of this conversation is that one disease can flare up the other, and then it flares up the other. And then you just are stuck in this cluster of what do I treat first? We did have a couple questions in the chat. So let me see. One that I want to bring up first is what are the contradictions and downsides that you mentioned of using Reglan? So you wanted to go a little further into that.
Yeah, so Reglan can cause a few things. In the acute setting, can cause dystonias, which are kind of this kind of getting locked up neurologically, where you're kind of stuck in a position. As one can imagine, really scary. Not incredibly common, but can happen. So it's a dialogue to have, certainly. Um, then in the long run, I think the thing that scares most providers is something called tardive dyskinesia, that it is a neurologic condition where you have constant lip smacking, kind of like this. And it doesn't go away after stopping therapy. So that's why it's really scary. The rate at which this happens is certainly less than 1%, but it goes up with chronic use as people get older, it's more common in females who are on antipsychotic medications like Seroquel, Abilify, and medications like that. So, even if someone is young and has none of those side like risk factors, I'm still pretty worried about it because it's such a terrible side effect. So I give vacations. So I usually do 8 weeks on, 2 weeks off. I'm kind of making that up. I think the box says 12 weeks on, 2 weeks off, but I tend to err on the side of caution there. But if Reglan doesn't work for you, there are other medications that one can try to help with stomach motility. One is erythromycin, which is an antibiotic. That is not without its faults either. You can kind of see a trend here that we are lacking in pharmacotherapy to help the stomach move. But erythromycin is one of them. It can prolong with something called the QTC, so you need to get an EKG beforehand and afterwards. But that also suffers from tachyphylaxis, which means the more that you use it, the less it works. So that's something that I also take breaks from. So I'll use that for 8 weeks at a time and then 2 weeks off. I don't have a lot of folks on it, admittedly. And then there's mestinon, otherwise known as pyridostigmine. Pyridostigmine is a medication that can help in POTS and helps get blood flow back to your heart and your brain. It also helps with stomach and colon motility. It doesn't work as well as Reglan and erythromycin, but it is an option. And last is something called Motegrity, which helps your colon squeeze. But there is some thought that it also helps with small bowel and gastric motility as well. But I don't see that a ton. I will also say that in gastroparesis, if you are not pooping, it's really tough to treat the gastroparesis. So that's one of the first questions I have is I say, how often are you pooping? And more often than not, it's really delayed for a couple of reasons. One, you can't get a lot of fiber in, you can't get a lot of water in, and the same process that is affecting the stomach is probably affecting the colon as well. So always kind of, if there's a backup on I-95, you got to start there before you hit, you kind of before you go to the stomach. And so those are all check boxes that I have. Yeah, that's my take on these medications. But Reglan, like anything else in medicine, is a tool, right? Like I don't have high blood pressure. I shouldn't be on a beta blocker, right? Or an amlodipine. I don't have an autoimmune condition, so putting me on methotrexate is a bad idea. But for the right person, it's a nice tool. So like everything else, it's a tool that you shouldn't be scared of. You just have to understand its limitations and the potential side effects.
That was really helpful. Thank you. Um, let's see. We've got another question. It says, so I've been having an MCAS flare for the last few months and it's been causing weekly anaphylaxis. I've been struggling with my gastroparesis and GI symptoms as a result. Stress is a big driver for my flares, but it's not the only driver. I'm trying to cut out garlic to see if that helps. I already follow the gastroparesis diet pretty closely and don't eat a lot of nightshades as much as I can. Do you have any recommendations for how to manage stress when life keeps throwing grenades at you? I've been diagnosed with central sensitization syndrome and can't take amitriptyline because I've had adverse reactions to it. I just got prescribed Effexor for my long COVID by my long COVID doctor, and I'm trying, and it's helping so far.
That's
So I
good.
know that touched on some of what we had talked about earlier as well.
Yeah, and I can't, give personal medical advice out on the webinar, but I think that mast cell can cause a lot of symptoms. It can cause almost identical symptoms to gastroparesis. I see a lot of like belching right after eating, bloating that happens almost immediately after eating. That doesn't really happen in gastroparesis. You kind of get this like full feeling, but not this immediate bloating. Um, and so, to break out of a flare, yeah, like managing stress is really important. Cutting out food is important. But in this situation, I think you need a medication. Mast cell activation is where these mast cells are trigger happy and they respond to everything. Like in my clinic in October, I get loads of messages like the second week of October because there's something thing called the October slide where people start to feel worse just because of the weather changes, right? And so you can't control all the variables. So maybe garlic is one of your triggers, maybe histamine is one of your triggers, and that makes you feel worse when you eat it. But globally, I think that pharmacotherapy is really, really helpful, if not pivotal, in getting someone out of a bind. Um, you know, antihistamines are kind of a nice place to start if you can tolerate them. But as someone has more severe mast cell, they start being intolerant of a lot of medications, including the oral medications like Benadryl, Pepsids, Zyrtec, and things like that. I tend to feel I kind of wrestled this for a while. I'm just kind of admitting to you guys that I struggled whether I would say, "Hey, try some antihistamines at home." And I think by and large it's okay because they're quite safe. And the Benadryls it sometimes can pick people up when they're in a flare, but not for everybody. And that's where you need an MCAS savvy provider to kind of work with you on this and kind of walk you through, okay, you tried Benadryl. How did that work? It didn't work so well. Well, let's try this. What are your symptoms? What do we need to look at next to pull you out of a flare? Because flares can be tough and they can last for weeks on end. I don't think there's an easy answer here. But yeah, in a pinch, antihistamines can be helpful for mast cell flares, but bigger picture is kind of understanding, what's driving, like what does your flare feel like? Is it that you can't stand up without fainting? Is it that you react and kind of have anaphylaxis to everything? Because that will ultimately depend on what therapies one should pull out to treat what's going on.
One of the questions here, and since you are a neuro GI and most of us don't see neurogastroenterologists and see regular GIs, do you mind touching a little bit on what the major differences are between the two and maybe what would make somebody say, I should see neuro GI over a regular gastroenterologist? So, why are you more awesome than everybody else?
No, 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 no. I just think I was focused on different things. So, and I did a GI fellowship. So I think, the most GI doctors are what are called luminal GI doctors, which means that they work within the confines of the pipe between your mouth and your butt. And if the answer is in there, those are your guys. Like they can find ulcers and Crohn's disease and ulcerative colitis and celiac disease and H. pylori and ulcers and bleeds and all that stuff that can cause a lot of issues. Um, they also can, most of these docs also have some ability to work on like biliary and pancreas stuff and also liver disease as well. Um, where I kind of come to play is not the structural abnormalities of the GI tract, but also how it moves and how it's perceived. So if you've had endoscopies, CAT scans, ultrasounds, stool tests, and everything is coming back normal, but you feel miserable, that's the time to see a neurogastroenterologist or a GI doctor. There are GI doctors that like to work in this space as well. Unfortunately, too many times people are just told that they have IBS, which is like IBS is real, I suppose. Like that's a different dialogue, but conditions that don't have a correlate on imaging or endoscopy there's so freaking many, right? And not all of them are IBS. And I can name you right now like 20, right? And most of them are just called IBS because they just don't have there's no relevant or helpful findings on the diagnostic workup. And so the neuro GI will help you navigate that world. Like, is this motility? And is this some flavor of IBS? Is this mast cell activation syndrome? And what neuro GI does, I think, is looks at the whole person, right? Like, how does your diet affect what you kind of affect your GI motility and how you feel? How does your stress kind of play a role here? Are there hormonal factors at play? Do you have mast cell? Like the reason I learned about mast cell is because, well, I didn't learn anything about this in training, but I kept having these patients that like were bendy and had easy bruising and endometriosis and POTS and migraines. I was like, what the hell is happening? This doesn't make any sense, right? And so it was just a step back to kind of just take in the whole person, then do some more reading. But, the traditional GI doctor is a proceduralist. Like they do procedures. Like that's 60% of their time is doing procedures. So their intent is not to sit in clinic and dissect these things. It's to do more procedures. And they're really, really good at it. So if you need a procedure, that's your person. They're closer to surgery than they are medicine and kind of hanging out in someone with in clinic and talking through some of these issues, which is what I do and what I enjoy doing. So I think in a very long-winded way, it's saying that if you have a lot of symptoms and the workup has been negative, it's time to see a neuro GI doctor. Neuro GI doctor.
Um, in that same idea, there's someone here talking about mals and asked if there is there a way to advocate or speak to my physician about doing the testing, and what is the testing for mals?
Yeah, so let's talk about what Miles is and why people don't know anything about it. And I want to give some context about training here. So I didn't start seeing it. I saw my first case like last year. And it is when the ligament that comes off the diaphragm called the median arcuate ligament is sitting on this nerve bundle called the celiac plexus ganglion, or the celiac plexus. Okay. So historically, how it was taught to me was that you'll never see it. And it's when the ligament sits on the artery called the celiac artery that supplies blood to the stomach. So the way it has been taught historically is that it's an ischemic process. That means that there's an insufficient amount of blood flow getting to the intestines. So when you eat, you get pain. Here's the rub is that I have more often than not, the patients that I see with malls have completely normal imaging. And so because the imaging is looking for the ligament sitting on the artery when actually it's the ligament sitting on the nerve bundle. So that it gets a little even more complicated because there's not even now a reliable diagnostic test for it. But I'll tell you how it looks in clinic and what I see over and over and over again. And quite frankly, nothing behaves this way, right? So when we're in medicine, we always think of a differential diagnosis. Someone comes in with a cough, I'm thinking pneumonia, postnasal drip, allergies, asthma, right? Like you have to think of a list of what may be going on. There's nothing else that causes this. Okay. Typically, not always, somebody with hypermobility who is bendy and sometimes has POTS too. Okay. It is pain after eating that is typically a couple finger breadths below the xiphoid process or the breastbone and happens almost immediately after eating or drinking anything. Um, Typically is associated with weight loss, 10, 15, 20, 30 pounds. The pain gets worse while taking a deep breath or exercising or exerting yourself. It typically radiates to the left upper quadrant, but can also go to the right upper quadrant. And it feels like your bra is put on too tight. Okay. And that story, primarily like the linchpin is everything hurts after eating or drinking and taking a deep breath. Like that's when I start thinking about it, especially someone who's hypermobile. Of course, you need a workup, and the workup includes an ultrasound. It's called a mesenteric Doppler, where they use an ultrasound probe to look at the celiac artery. And there's some maneuvers that you have to do with it. There's an inspiration phase and an expiration phase. And if that artery seems clamped down by the ligament, then that could be diagnostic. I know I just said that I think it's the ligament sitting on the nerve. Then why do the testing to begin with? Mainly because if that's positive, you go right to surgery. Okay. Because you do need some objective-ish marker to say that you have it for subjecting someone to a pretty big surgery. Okay. There's also a complementary test called a CT angiogram that will look at the relationship between the diaphragm or the median arcuate ligament and the celiac artery. If testing is negative, so it's a mesenteric Doppler with an inspiratory and expiratory phase and a CT angiogram of the abdomen and pelvis. If it is negative and there's still suspicion for median arcuate ligament syndrome, then I will perform or I will refer for what's called a celiac plexus block, where our colleagues in interventional radiology will numb the celiac plexus. And if that alleviates pain altogether, in fact, you'll find someone who hasn't eaten in weeks and is having a lot of pain, is losing weight, and they'll go home and eat a cheese pizza and a burger. And they feel amazing for a day, 2 days, 3 days, and then it wears off. And that is proof of concept that they would benefit from a surgery. And there's only a kind of a handful of surgeons that are comfortable doing this surgery. So that's kind of a different dialogue altogether. The biggest for the person who is kind of on this thread, if they are concerned about malls, the number one priority is getting nutrition, though, because more often than not, people are not eating anything. And they can become drastically malnourished over a short period of time and develop fatigue and just everything that comes with really effectively getting less than probably 300 to 400 calories a day. And so the first thing I ask them is, how are we going to get you calories? So oftentimes I'll place an NJ tube, which is tough, not fun. Nobody likes it. But in someone who can't eat, sometimes it's kind of a welcome reprieve that they don't have to think about what they're going to eat or have the pain they're going to have after eating. Because if you bypass the stomach and this tube goes into your nose, through your stomach and into your small intestines, you don't have pain and you can get some of your energy back and start feeling better while we implement a plan to work this up and treat it. Because quite frankly, the workup can take on the order of months. The person ordering the test doesn't have control over the radiology schedules or the surgical or the surgeon's schedule, right? So it can take 3 to 4 months to get this all situated, which is really, really challenging. And so sometimes kind of aided nutrition with a nasojejunal tube is necessary. I know it's kind of I way overstated kind of malls, but I feel like it's misunderstood by a lot of people in healthcare. And I'm trying to kind of push the narrative a little bit more that this is kind of what we see and what we do, and it works quite well.
Yeah, I didn't know a lot of that. So I even myself with people with knowing people that have it and have gone through the surgeries or might go through the surgeries, that's it's a long-winded explanation, but I think a very needed one because like you said, a lot of people don't understand it. And when you're relying on your providers who might not understand it, you're kind of just stuck, really.
Yeah.
Um, Another question we have is asking for any tips for gastroparesis and colonic inertia. I have gastroparesis and severe constipation and relying on laxatives. Is it common to have severe constipation with gastroparesis? Which
Yeah.
I know we talked about that a little bit, but
Yeah, there's a high rate of comorbid dysmotility, more distal to the stomach in the small bowel and the colon. So I always talk about constipation first. And it's really tough to do without laxatives because the colon just isn't moving very well. And so, I always talk about like how much water are you taking in, how much fiber are you eating. Obviously, fiber is a tricky conversation. Like you can't eat a kale salad; it's just not going to work. It's not going to feel great. So there are fiber supplements that are better tolerated in those with altered motility. One is called partially hydrolyzable guar gum by Sunfiber. It doesn't ferment because if you take like a ton of you know psyllium husk, it's going to sit in your small bowel or your colon, and it's going to ferment for days, and you're going to blow up like a balloon. Or that was it Veruca Salt? Who's the girl in Willy Wonka who blew up? In any event, I just read my kid Willy Wonka, so it's on my brain. It's on my mind. Um, so. Uh, yeah, and so I do. Sometimes you have to use, not have to, but it's encouraged to use a laxative. And I'll start with a pro-motility agent like Motegrity to start. Motegrity is a really safe medication. It's a serotonin agonist, a 5-HT4 in the colon. Can help. I think someone asked, can it help in the stomach? I don't.
mm,
It's I don't think so. There's not a lot of data out there, and I don't see it work tremendously for proximal motility as opposed to colonic motility. Um, and then we kind of assess how you do on that. And sometimes people need additional laxatives as well, like Miralax on top or Linzess in addition to it, if it's really, really bad. If someone has tremendous dysmotility where nothing's working, then invariably there's an autoimmune process at play, like Sjogren's or autoimmune autonomic ganglionopathy, which requires like immunotherapy. But for kind of symptomatic relief, those kind of pro-motility agents like Motegrity can help. And there's also Mestinon can help a little bit as well. It's also kind of a pro-motility agent. But yeah, I'm very quick to put someone on a motility agent just because medications like Linzess, Amitiza, Trulance just aren't exactly well targeted for these folks as opposed to like those medications, for example, just bring a lot of water into the intestines. It's like Miralax on steroids, but you want something to help with squeeze. And that's where Motegrity can play a role. Oh, it's a lot of people are like, oh, my insurance won't cover it. For on GoodRx, it's like $40. And you can also get it from Mark Cuban's pharmacy, cost plus in Florida. And it's like $16, the generic. So a lot of people are like, oh, well, my insurance says I have to try 6 things first. Forget that. Like just go backdoor it, cost plus GoodRx, like they have reasonable prices there.
good. Thank you for that. That's very good to know because it is
It's
very
tough.
expensive. Another question we have are patients with gastroparesis are sometimes being told they don't have gastroparesis and instead have functional dyspepsia. Are there treatments for dyspepsia and is it in my best interest to embrace that new diagnosis?
I think it's tough. So functional dyspepsia oh gosh. All right. So I'm going to marry my old brain with kind of my new brain. So functional dyspepsia is pain in the epigastrium after eating. Okay. There's different flavors of it. There's epigastric pain syndrome, postprandial distress syndrome. And yes, an endoscopy and a gastric empty test is warranted to make sure that it's this kind of functional dyspepsia. The therapies that are employed are high dose proton pump inhibitors, neuromodulation, okay, like amitriptyline, Cymbalta, things like that. They tend to work okay. Here's the thing is that I've also found that a lot of my patients that were previously diagnosed with functional dyspepsia, if you step back and talk to them, they have a lot of other symptoms in their body: fatigue, sinus issues, um, uh, tachycardia, POTS, allergies. And it makes you think like maybe this functional dyspepsia isn't a functional condition, which is a disorder of the brain-gut interaction that requires neuromodulation, but it's actually a manifestation of mast cell activation syndrome. And so I will say that mast cell is something I only learned like 2 years ago. I know I'm on Instagram talking about all this all the time. I'm a relative newbie in this game. I found it because all these folks started I guess what I'm trying to say is that when you see a GI doctor, they're going to talk about your GI symptoms. But what's weird about mast cells, rarely do people step back and take in the whole picture because one, there's not enough time, and two, we're not really trained to look at MCAS. It's kind of a relatively new thing. So what I would say is that functional dyspepsia, one, you got to make sure it's actually that. If you have mast cell type symptoms, maybe this is just a manifestation of mast cell activation syndrome. You want, a lot of people think malls is functional dyspepsia, right? You have pain immediately after eating. But if it's after eating or drinking like anything and you're losing weight, that's something different. Functional dyspepsia doesn't cause weight loss. So I think functional dyspepsia is a real thing. It can get better with like proton pump inhibitors and neuromodulation. And sometimes if people feel that like their thoughts, their emotions, their feelings kind of drive their symptoms, and maybe hypnosis or cognitive behavioral therapy can be helpful as well. So it is a real diagnosis that does affect a lot of folks. But there also are very similar diagnoses that are kind of put under this FD, functional dyspepsia umbrella, and treated with medications unnecessarily, and it doesn't really work. But yeah, it is a real thing and it can happen. There's a lot of nuance to it, right? Like, is that the right diagnosis? And yeah. But the good news is if you take a PPI or neuromodulation, it is not forever. You start it, you assess response, and if you're getting better in 12 to 18 months, you're usually able to wean people off therapy successfully.
Um, do you have any advice as to how to manage changes in gastroparesis treatment while being in the process of getting diagnosed with MCAS? Recently, been put on a form of enteral nutrition for gastroparesis and trying to figure out what's causing the chronic allergic reaction like symptoms that they've had for years, which might be MCAS. Not, I don't want to make my doctors think that I am being dramatic or anything.
Oh God, I hate that you have to feel that way. I'm so sorry. Because you should be dramatic. This is tough. This is like really, really tough. Like you can be however you want to be because this is really challenging. Yeah, I mean, so nutrition in mast cell is tough, independent of motility. So you want to support motility the best you can, but the nutrition piece is tough. Some people are limited to like two foods, right? And some people can't eat anything, and that's where you have to do, an NJ tube or something like that, and give kind of elemental nutrition. So some people who can't eat anything, right? I sometimes put them on elemental diets. It's already pre-digested amino acids that shouldn't cause a mast cell reaction, but it's really tough. It's such a nuanced conversation. So again, step one, make sure you're getting the right nutrition. And like that is the most important thing. So is it an elemental diet? Do you need TPN? Do you need an NJ tube? Like what can you tolerate? And then it's to kind of treat the mast cell. I will say that I have tons of people who have symptoms identical to gastroparesis, but their gastro emptying study is normal and they get full early and they belch and and that's mast cell can do that exact thing. And so mast cell therapy can also often help these folks. But it's a tough balance to strike, and you really need, like when I see my patients, there's a nutrition plan, there's an MCAS plan, and there's a motility plan, right? And so if this is gastroparesis, then make sure you're pooping. If you need a pro-motility agent, use a pro-motility agent. If you have comorbid like profound autoimmunity that's making everything slow, to use like immunotherapy. And then mast cell therapies, that's seemingly a very important step here if you're so reactive to everything. And then, yeah, what are we going to do for nutrition? Because that's a critical step here.
There's a couple questions here, but it goes back to what you were talking about, Reglan. When you do 8 weeks on and 2 weeks off the medications, do you stop it or do you have to wean off of it?
You can stop it. You can stop it. And then depending on how symptomatic you are during those 2 weeks, like do you either just reduce down to like a liquid diet, depending on how symptomatic you are? Um, do you just go to like smoothies for a couple weeks, or do we kind of give you a little dose of erythromycin for those 2 weeks if you really can't tolerate anything? And that's one other button you can press is, okay, well, now you're swapping therapies that both need vacations. And because I think a Reglan works better, I will kind of favor that and then maybe substitute erythromycin for the interval vacation there.
This is a hard question. Do you have a recommendation to combat the October slide?
Um, that's a really good question. Yeah. So how I think of it as an analogy that I use is that mast cell, like you have your boat, right? And when you're not on any therapy and you don't know the rules of mast cell, your boat is rickety and there's holes in it. So with some guidance, understanding triggers, dietary changes perhaps, and medications, you build up that boat. You can't control the ocean, okay? But if you build up that boat strong enough, perhaps the October slide isn't as strong. But there should also be an opportunity to be able to have a bucket to help kind of get water out of your boat when the waves are high. And so in someone who slides, I usually like there are medications you can use to kind of withstand the slide. Like, we use medications like Benadryl, sometimes benzodiazepines. There's mast cell, they have mast cell. There are receptors for benzos, or so to speak, on mast cells. So those can really help in a pinch. Something called azolastine, which is a nasal spray, can be helpful too. Singular can be helpful, and so can Celebrex, and prednisone if when all else fails. So I think it's building up the ship, anticipating flares like plane rides, like ridiculously hard for people with mast cell. So we create a pre-plane ride plan to kind of get you through. So you can't control everything. I do have people that have moved to like Europe because they feel so much better in Europe because I think food that you eat, the chemicals, the dyes, there's more regulations on food, so to speak, that they feel better, but there's only so much you can control. So yeah.
Now this one, you had mentioned endometriosis earlier, and they were asking if it's commonly seen in gastroparesis or MCAS patients.
MCAS, yes. MCAS, yes. Almost everybody. Not almost everybody, but I'm making this number up. 60%, and a lot of young women who have heavy, painful periods that haven't yet been diagnosed with endometriosis, or have had heavy, painful periods since they reached puberty and then were immediately put on birth control. So they have endometriosis, but it's subclinical. And I am not an OBGYN, so I don't want to go out of my lane. But what I've read is, so mast cell seems to be a pretty pivotal step into kind of allowing those endometrial implants to kind of grow and become inflammatory and painful. So part of the endometrial, like when it implants, there's some process where the mast cells get turned on, and that causes like angiogenesis, where they start getting blood supply and start causing pain. And so it seems that mast cells are kind of play a big role in the presentation of mast cells and the pain that's associated with it. I don't know in terms of like if mast cells cause it, but definitely can lead to the clinical manifestation. And I just like, if there's any OBGYNs in here, like tell me to shut up or poke holes in my argument, but this is just my interpretation of the data. And it's just something that I clearly look out for in folks, especially in those who like are trying to conceive or having a lot of painful periods and don't want to go on birth control or just wondering what's going on. That's certainly a dialogue that we commonly have.
Now we've had a couple different questions about your practice and different like payment options, location restrictions, et cetera. Where can we direct them for that information? Would that be to the website where they could maybe either reach out to you or someone in the office to get that information?
Yeah, I'm going to be super candid here. I hate that we take cash. There's no other way to do it. And we take cash for a reason, because this world of mast cell and POTS, there are no data points that tell you exactly what to do. So I spend hours upon hours on the MyChart or our patient portal talking to people, going through flares, being like, okay, we've done this medication for 3 weeks. Oh, you don't feel any better? I'm so sorry. Like, let's go in this direction. And guess what doesn't reimburse for that? Insurance. So when that's why we charge cash. And I'm really, really sorry for anybody that can't afford it. It breaks my heart and it keeps me up at night. We're trying to think critically over time about how we can take insurance. It just, with this model where to give people this much time, 9 hours a week, people send me pages and pages and pages every day, and that's okay. We want them to feel like you can talk freely about what's going on and how crappy this is and what we can do better. And so there's no way to get reimbursed for that. Like when you go see a doctor, the reason why they see you in 15 minutes is because insurance only pays like so much for a 30-minute visit. So you just need to crank out a lot of visits over a short period of time to be profitable. And what really makes profits is procedures. So if you're not doing procedures, it's a tough place. It's a tough place to live. So for that, I just say from the bottom of my heart, I do apologize. And it was a tough decision. That said, to get down to like the nitty gritty, we are a telehealth practice. We give patients a lot of time in clinic to go through these issues. you have to be in North Carolina or Illinois at the time of of the visit. So you don't have to be a resident of the state. You just have to travel there. Um, the finances are on our website. I'd say compared to our kind of concierge colleagues, we are charging pennies on the dollar, so to speak. And we are always mindful of the prices that we like, the tests that we order, medications like that factors into consideration here because we not only need to make a plan that works, but a plan that worked for, God willing, the next couple decades. And in a world in POTS and MCAS where there's no FDA-approved medications for these things, like we're just kind of duct taping this ship together. Unfortunately, we are booked out for quite some time. I think over a year at this point. So I can't see more people, but we are hiring a lot of help. So we have new providers coming in next January and next spring and maybe next fall as well, expanding to other states potentially, and be able to see more people because we want to help. And we recognize a lot of people are misunderstood by their providers because either they haven't been taught about this or they don't want to kind of go down this rabbit hole with you. There's a lot of people struggling out there, and we want to be available and be affordable. So we're working towards it, and we love all the feedback. So please bring it on. I've never run a business before, so I'm just figuring this out as I go. So I'm open to all the feedback.
Would we be able to maybe get like some of those things answered if I follow up with you after with
Absolutely.
questions?
Yeah.
Okay. Well, then I'll grab one more before you have to run. Just do you have any recommendations anywhere for a specialist who can analyze why I'm reacting to TPN? They've been on it long term for 13 plus years, taking Pepcid, Zyrtec, IV Benadryl, Reglan, Motegrity, Amend. It makes POTS go insane, and heart rate will say 150 plus beats per minute for the entire 8-hour infusions. Feeling like reacting to something, but that's clearly not normal.
Oof. Yeah, I mean, so triggers trump everything in mast cell. You're not going to be able to beat it with a medication. And so you're reacting to something in the TPN. So it requires where I would start, and I've never seen anybody have a reaction to TPN like that. But where I would start is I'd have a conversation with the dietitian. What's in there, right? And what can we do differently to reconstruct the makeup of the TPN to see if we can give you different formulas that may make you react less. So as always in mast cell, we always look for the triggers. And it's easier said than done. And that also goes to like the tubing that they use, right? Like everything. You have to really play Sherlock Holmes and deconstruct everything that goes into that TPN process and then kind of really kind of reverse engineer it to figure out what your triggers are.
Yeah. Thank you for answering all those questions. I will, since we record everything, I've got all the questions from the chat and we'll just follow up with some generalized answers from everybody. But thank you so much for chatting with us and answering all our tough questions today. And again, if anybody else has any other questions, you can follow up with me. Just send me an email, and we'll do our best to get that answered. So thank you.
Thanks, Samantha.
Bye.